We got into the future a little bit on the last panel, but this panel is going to do even more so. The basic question is, what have we learned from the experience of the Affordable Care Act in the last 3 years, either from these studies or from other research, which will be well represented on this panel on the Affordable Care Act? What have we learned that would improve insurance competition and affordability as we look ahead? And we have a very qualified group of people here to help us answer that question. We have 3 researchers who have been doing research on health and health insurance markets and healthcare generally, and the ACA in particular, over quite a long time to help us assess what we have learned in this study and elsewhere. And we have 2 members of the network from states we haven't heard from until this moment, namely Colorado and Indiana. So we will hear first from Linda Blumberg. Linda is a very distinguished health researcher who's spent quite a long time researching these issues at the Urban Institute, where she's a senior fellow in the Health Policy Center. We will hear from Stuart Butler, my colleague here at Brookings, a senior fellow in the Economic Studies program, who actually spent quite a long period researching these same issues at the Heritage Foundation, and his point of view has not changed, so far as I know, in moving from one place to another. We have Cynthia Cox, who is the Associate Director of the Program for the Study of Health Reform and Private Insurance at the Kaiser Family Foundation. I don't know what we would do without the Kaiser Family Foundation. None of us would be very well informed about healthcare or these issues. We have Michelle Lueck, who is the president and CEO of the Colorado Health Institute, who has done fascinating work on what's going on in the mountains of Colorado and in the plains as well. And we have Kosali Simon, who is at the University of Indiana in my home state. I'm a Hoosier, and Hoosiers are big these days. Very, very important to pay attention to what's going on in Indiana. Kosali is the Herman B. Wells Professor at Indiana University. So, Linda, start us off.
Okay, great. Thank you so much, Alice. So when we look to what the future of competition is going to be in insurance markets, it's actually very hard to know right now, obviously, as you all recognize, what policy changes are going to take place and how fast they're going to be implemented and in what stages. But what we do know is that there's a very different general direction in the policy proposals that are being put out at this point. That there's a fundamental philosophical shift at play here in terms of how sharing of healthcare costs would be done in private insurance markets. The Affordable Care Act is firmly grounded in the objective that healthcare costs be shared more broadly across those who are healthy and sick than was the case prior to 2010. And in almost every state, that meant for the first time that there could be competition in the way economists think about competition in the private non-group insurance markets, which is to be trying to promote competition based on price, based on network, based on customer service, other quality measures. And that was really catalyzed for the first time by these changes under the Affordable Care Act. So, for example, the Medicaid expansion, the premium and cost-sharing subsidies, these all are mechanisms for spreading healthcare costs through the tax system more broadly, the whole tax-paying population. guaranteed issue in the non-group market, limits on premium variation by age, prohibitions on medical underwriting, essential health benefit requirements, actuarial value standards, and on, the individual mandate, were all ways to share healthcare costs more broadly across the population enrolled in private non-group health insurance policies. And those who were healthy at a particular point in time were then, as a consequence of this broader sharing of risk, potentially going to spend more money depending upon their eligibility for different subsidies, but the costs for those who had health problems went way down. In contrast, when we look at the types of policies that are included in the proposed alternatives to the ACA, 201, they would move us further towards segmentation of healthcare risk, the separation of the costs of the healthy from the sick. And it's a highly consistent philosophical framework that we're looking at in all of these proposals and their components, and this has very substantial ramifications for the ability to create real economic competition. What it does is these segmentation approaches are going to promote competition based, again, on what we saw before the Affordable Care Act, which was insurers trying to get the best healthcare risks, not becoming the most efficient providers of medical care. So just a couple of examples, but there's a lot. The elimination of essential health benefit requirements and actuarial value standards, for example. These approaches are going to reduce the comprehensiveness of insurance packages that are offered in the private non-group insurance market. We'll see higher deductibles, and premiums are going to be lower as a consequence, yes, but there's going to be a much higher share of healthcare costs that are put on the individuals who need medical care when they need it. You eliminate prescription drugs or mental health care or other benefits from an insurance package, and again, the premiums will come down. But for those individuals who need those particular services, they have to incur all of the costs of that particular care themselves, and for many of them, that means they won't be able to afford it at all. So these are, again, shifts away from sharing of healthcare risk to separating healthcare risk between the healthy and the sick. In addition, when you think about any promise of pre-existing condition exclusion protections, they ring really hollow in a world without essential health benefit requirements, because what does it mean if I'm not getting excluded from my policy based on the fact that I have cancer, but my policy doesn't cover chemotherapy and it doesn't cover radiation? It's a pretty meaningless protection. So another example, age-related tax credits instead of income-related tax credits. When you take an amount of federal dollars that you're going to use for financial assistance and you spread it over all individuals in that market, not just those who have low income, each individual is going to get less amount of assistance than they would have if it was income related, for those who are eligible. So again, people who are middle, lower income can only afford policies that have higher cost sharing requirements, lower benefits. Again, separation of risk. In addition, we see in those proposals, at least the ones that have specifics in them, that while there are increases in the assistance that are available based as your age increases, those increases in assistance do not increase as much as the premium. So if you go from 3-to-1 to 5-to-1 age rating, a 64-year-old can be charged 5 times as much as a 20-year-old, for example, but the tax credit only goes up 2.5 times. Then the affordability of care as you need it, as you begin to need more healthcare services, goes way down. Okay, so again, separation. I could go on and on with regard to high-risk pools, continuous coverage requirements, individual health pools, expanded wellness programs, all cross-state lines, sales of insurance. All of these things end up separating risk more. We could put in place instead an array of strategies that would be more towards allowing us to have better competition in these markets in the way that economists think about real competition. Some of these have been mentioned before. I'll mention a couple of more. We should be doing more to increase enrollment. We're not doing enough to bring in enrollees that are out there in terms of both improving the financial assistance, the subsidies, but also doing more outreach and enrollment activities. We should be fixing the family glitch, bring more families into the non-group market who need that for affordability. We also should be regulating non-compliant plans that are pulling some of the better risks out of the pools. In addition, for those markets that are highly concentrated with insurers or providers, we should, in addition to the idea of the public plan option that was mentioned before, I'll mention another option, which would be to use based on the Medicare approach, where in Medicare Advantage, insurers cannot no provider can charge an insurer more than the traditional Medicare rate, even if the individual goes outside of the plan, outside of the network. Basing something on that, Medicare plus some percentage for non-group insurers could create more competition in these very highly concentrated markets. I'll stop there. I have other ideas we could talk about later, but I've run out of time, so thank you.
Okay, thank you very much. Stuart, you've been focusing a lot on state flexibility and the potential for increasing that, which we haven't talked about very much in the previous panels. So I wonder if you would focus on that.
I will. And of course, you've asked us to think about what does all this mean, what we've heard this morning for the idea of an ACA replacement, or I guess today we're talking about an ACA repair. Although my favorite sort of expression would be an ACA extreme makeover. I think that's a much more Trumpian kind of way of thinking about this. But anyway, and I think, two things have come through very loud and clear this morning. One is it's not just politics, but markets are local, certainly between states and within states, as we've heard, so the locality, and also that markets change over time, as we heard with Florida and others. Things may work in a certain way at the beginning, but they change over time. So I think when we start thinking about what should the federal government do, or how should the federal government's role change in any revamping of the ACA, I think it's clear we can't have much confidence that some pattern will work everywhere, or that a pattern in fact will work in the same way over time. And that certainly leads me to think about the role of states and the role of state flexibility in this. And I would say there are kind of three broad approaches that, if you think about it at the 50,000 feet, or three broad things that are needed. First is, I think, for the federal government itself, not to try to do too much. Socrates told us many, many years ago that the first step to wisdom is knowing your limitations. And so I think we ought to recognize that the federal government is limited in what it can do to kind of micromanage the changes across the country. And Micah earlier on said, you've got to have a federal law that you can explain even to a journalist. And I think that's important to bear in mind, so sort of simplicity. It seems to me that in thinking about this, the federal government's focus in the future would be thinking much more strongly about what are the goals and what are the protections that there have to be in place, some of which have been mentioned already, including by Linda. And also that, yes, the federal government should do its best to try to design things at the national level. And many of us have put forward proposals, including Alice and I and Lauren Adler more recently, about ways we could tweak, change the ACA. But the second point I wanted to make after that is that in so doing, it should allow the states maximum opportunity to find the best ways and to experiment with best ways to reach those goals and protections. As you know, I think in the existing Affordable Care Act, we have a section 1332, which says essentially, if you don't like mandates, if you don't like the exchanges, if you want to reorganize all the subsidies, go ahead, providing you maintain certain protections, financial and other, for individuals. So we have actually within the Affordable Care Act now an enormous opportunity to have wide variation and experimentation at the state level. The Obama administration was both slow and narrow in giving any kind of interpretation of that section, but a Trump administration, actually at a stroke of a pen, could significantly widen what states can do in this area. And I think it's very important to encourage states to take use of this provision, also to interpret it, if I can use the term more liberally, in terms of allowing the budget neutrality, for example, to be available across programs rather than narrowly within programs, which is what the administration argued. That means you can start looking at combining or looking at Medicaid and the subsidies and so on together and figuring out what is the best way to get people covered and to deal with some of the adverse selection issues. So I think there's enormous opportunities in that. The third area I would just say very quickly in wrap-up is to say we've got to do a much better job at allowing states to learn from each other. This very project that we're talking about this morning in terms of looking at states is one step to do that, and that's important. Kaiser Family Foundation helps us as well. The National Governors Association and its Center on Best Practices is looking what's going on in the states, but we've got to do a lot more to allow a learning process between the states so that if we give opportunity for experimentation, then we really can learn from each other more effectively. So I think there are things that the federal government can do, even within the existing legislative framework, let alone changing it in the future, and we need to make maximum use of that.
Stuart, can I ask you just to respond a little bit more explicitly to Linda? Are you, because she made the point that a lot of these regulations and narrowings that you worry about spread risk over the sick and the well, which was the objective. And are you buying into her all of those protections? I mean, at the state level, suppose with this increased flexibility that states said, well, we don't care about the essential benefits.
Well, I think we've got to be very clear about what the protections and what the bottom line is. I think there can be a debate over whether the essential benefits package is both too specific and too large. That's a reasonable debate. My point is that I think that's what those general protections would be is an appropriate debate at the federal level, and it's a national issue. It's a values question to a large extent. But we ought to allow maximum opportunities for states to figure out how to reach that through essentially a waiver process, which, as you know, means that it's got to be plausible. There's got to be a clear plan presented to the federal government. It's not every state just does whatever it wants. And I think as part of that process, you always do have to look at, are the protections and requirements that we're putting forward at the national level, are they viable, are they achievable across the states? That's got to be part of the ongoing conversation, it seems to me.
Cynthia.
Well, I guess I would start by doing a bit of a post-mortem on the ACA and what we've learned. Not that the ACA is dead yet, but I think, before we can really look forward into what the repeal or the replacement or the repair would be, I think it helps to look back and see, as we've been doing today, what worked, what didn't, and so I would just add some takes that I think go along with what we've already talked about this morning, but that the Affordable Care Act really fundamentally changed the nature of competition in the individual health insurance market. We went from a system where insurers, by and large, would compete by trying to avoid sick people to one where there's guaranteed issue, guaranteed renewability. But not only that, but consumers now are enabled in a way to shop around for coverage in a way that they never could before, and in fact are encouraged to do so by the way that the tax credits are structured in the Affordable Care Act. And we heard earlier about how the tax credits are quite complicated, with the second lowest cost silver plan in a given county or rating area. And it is complicated, but at the same time, I think that it did work. I think there is evidence that this structure worked to encourage consumers to be price sensitive and to shop around based on premiums, and that insurers saw quite a bit of incentive to offer a low-cost plan. And in fact, maybe it worked too well, because looking back at premiums, and in 2014, premiums came in on average nearly 20% lower than what the CBO had projected they would be. And at the time, that was hailed as a success of the ACA and success of competition in this market. But with 2020 hindsight, and now knowing that many insurers have lost a lot of money in this market, those premiums were likely too low. And I think the question becomes, was that because the people who signed up were sicker than what insurers had expected? Or was it that they had underpriced, maybe intentionally, to try to pick up market share? And I think it could be both. I think it's maybe a combination of the uncertainty that insurers faced in entering into this newly reformed market, and the inability to accurately price early on. But also, it was likely because of this cost share, or the tax credit structure that existed in the Affordable Care Act. And we can look at specific states, especially where premiums came in exceptionally low, to see that in many cases this was actually damaging to the market. And we've seen significant premium increases in some of those states where premiums came in too low. But even putting aside the premium increases, which have been quite large this year, I think there's reason that we knew that premiums would increase in 2017. Not only because of inaccurate pricing, but also because the reinsurance program was phasing out in 2017, and because 2017 was really the first year that insurers had this accurate data on which they could base their premiums. And so while there's been a lot of concern over the viability of this market, I think that a lot of these issues that we've seen come up around premiums and participation were foreseeable, and were in some cases maybe preventable, but at the same time, just looking at the dollar amount of the premiums in 2017, they're really quite similar to what we would have expected 2017 premiums to look like at this point. I think premiums just started out low, stayed flat, and then increased very rapidly in the last couple of years, rather than increasing more gradually, and so that gives the appearance of instability or looks very very risky, for an insurance company's perspective, or from, a perspective of whether or not this law is working. But at the same time, kind of taking that step back, we can see that really, as far as premiums are concerned, the market is maybe where it should have been to begin with. And what states or the federal government could have done differently, maybe to mitigate some of this, we can look at the rate review program, as we've heard also, there was the risk corridors program was underfunded. Outreach and enrollment maybe could have been stronger to get more people in, especially the young and the healthy people. And also states that had implemented transitional policies and Medicaid expansion, or did not implement the Medicaid expansion, tended to have sicker populations in those states. But I think that if the election had gone a different way, this maybe goes without saying, but we would likely have a very different conversation today around technical changes to the law, and I think that we can still have those conversations too.
But we are where we are.
Yes.
So the question is, what happens as we move ahead, and what would best improve competition? Michelle, you want to talk about this question?
Yeah. Good morning from the Centennial State, and thank you, Alice, for the opportunity here today. I approached my preparation and homework for this panel a little bit differently, and I went out and talked with 3 state leaders. And the first person I talked to was a senator who is part of the Republican leadership of the Colorado Senate. And I asked him sort of what all this means, and Senator Jack Tate said, "We are doing absolutely nothing. We're taking our cues from Washington. We are in a watchful waiting mode." The very next day, they issued a repeal of the exchange, the legislation in the state, so I don't quite know how that adds up. I talked to the director of Medicaid who sits in Hickenlooper's cabinet, and she said, "We are moving ahead. We are full of momentum, and we are going to be going so strong and so fast and so energetically that there'll be no stopping us when repeal, replace, or repair comes along." And then I spoke with the lieutenant governor and asked her the same questions. And Donna Lynn shared with me, she goes, "Well, we can go on our merry way. We are going to be the staunch Democratic state that we are currently, although we're very purple. But we are led by Democrats." And she said, "But we have to have a plan B in our back hip pockets. We need to be able to file for waivers and sort of turn on a dime when things happen at the state level." And so when I thought about how I would summarize all this for you, I thought about this being sort of cognitive dissonance, if you will, as it's playing out in Colorado. But the longer I thought about it, I thought of it as just being dissonance. I mean, what's happening on the ground is really very, very hard to report on at this stage. We are a purple state, and we also characterize ourselves as being an all-in state on the Affordable Care Act. We expanded Medicaid, we built our own exchange, we applied and won lots of CMMI, SIM innovation model grants, and we dabbled at having our own health insurance co-op. And we are very much at the Colorado Health Institute thinking through what it means to reverse all that and become an all-out state. And how that is all transpiring is very hard to tell, at least in Denver. I thought about the report that's been released today and wanted to share 3 observations about how it's the same and different than what's happening in Colorado. And the first sort of hypothesis that the report issues is that, that health insurance markets are local. And I would suggest that we put a big asterisk next to that, and also comment that health insurance markets may be local, but health insurance carriers are certainly not. And we've seen in Colorado 3 health insurance providers that are local, regional non-for-profits either go under or are struggling immensely. The co-op was around for about 12 months. And then sort of dissolved just about as quickly as it came into existence. Rocky Mountain HMO, which has been in the market for about 50 years, it's a local regional provider, didn't have the cash reserves at the end of 2016 and was merging now with United Healthcare. And our other regional player is Colorado Access, which comes from a Medicaid history. And that organization has put out 2 cash calls to its owners in order to come up with the reserves that are necessary to keep it in existence. And so I'd like this to think about the interplay between the markets and the carriers, because it's a very different story when you're looking at the carrier environment. The second observation is that I think that the consumer confusion that was hinted at the first in the first panel cannot be underestimated. In Colorado, consumers did not know where to buy health insurance, and so more people buying on the individual market bought off the exchange rather than on the exchange, and they didn't know what to buy. And in Colorado, the bronze plans, we have the second highest level of bronze plans purchases. And we think that that's an indication that the other shoe will drop when people don't understand that they've only bought a plan that represents 60% of actuarial value. And then finally, my third comment about the report and sort of thinking and casting that into the future is that affordability continues to be the elephant in the room. In the health insurance premiums in Colorado, increased last year in 2017 by 20.5%. But the range, if you look at these county variation, ranges from 16 to 42%. And that's a heavy lift for consumers. And I don't think that we see a lot of attention paid to how we're going to not just create the shell game of reallocating regional markets or rate, so that the cost shift is absorbed by different people at different times. But how do we get to fundamental issues about the true cost drivers within the system is something that I think needs to be reconciled in the extreme makeover. Thanks.
Thank you. Do you want to give us just another couple of sentences about the true cost drivers? Where would you go with that?
Well, we have the ski resort communities in Colorado have some of the highest health insurance premiums in the country.
It's a dangerous thing to do.
It is a dangerous. Lots of knees need to be replaced. Apparently, it is politically unpalatable to subsidize the residents of Aspen and Vail, Colorado, for obvious reasons. And I think that we've played around. CHI was commissioned to do one geographic rate study, like what if everyone's in the same rates. We've reconfigured the markets a couple of times, and I think that just changes, frankly, who calls legislators to complain about their rates. And so sometimes the western part of the state is absorbing the costs, and sometimes the eastern part of the state is. But until we think about things like competition and lack of competition in those markets, particularly around hospitals and providers,
provider markets.
It'll be a problem.
That's certainly been a theme. Kosali, tell us about Indiana.
Yes, so Indiana is relative to the 5 states that have been profiled, close to Michigan, and I'll talk about in what ways it's close and what ways it's different. So both have Republican leadership, both have been very active in designing state-based solutions to Medicaid. But Indiana has been different in using a federally facilitated marketplace, whereas Michigan used a partnership model. So Indiana has been especially active in coming up with this, the Healthy Indiana Plan. And so that's a way in which I think we'll talk about how is Indiana different, because as was mentioned, there are these spillovers between how a state approaches Medicaid and then its marketplace. In terms of carriers, so Indiana started out with about as many carriers as we currently have. There was a change in the middle where there was more entry, and then from 2016 to 2017, an exit of some carriers. But in terms of premiums, we started out in 2014 with premiums that were higher than the national average. But we've had slower than nationally average growth, as well as reductions in the benchmark average premiums over those last few years, so that currently Indiana's average plan premiums are actually lower than the national average. So Indiana was in the news in October of last year when 2017 rate increases were announced as having the state having 3% of a reduction, whereas nationally there was a 22% increase in those benchmark premiums. So in terms of how many people we've got a state of about 7 million. We've got about 170,000 people in the qualified health plans, in the marketplace plans, about 83% with subsidies. So on those are not surprising in those kinds of areas. The carriers are present in many of the counties. So most of the counties in Indiana have 3 or more carriers that are competing. The insurers that left cited profit that were negative, and also the risk of reinsurance going away as reasons for exit, although those insurers did stay in the wings, as was mentioned, because they participate still in the off-exchange market. There's only HMOs, as in many markets, that are available as choices. And so I'll just close by mentioning the other thing that Indiana has been in the news for lately, which is that last week the state filed the extension waiver for the current Healthy Indiana Plan. And that went in on January 31st, so there's a 30-day period of public comment, and then after that we'll see discussions between the state and CMS. And that continues many of the features of the current Healthy Indiana Plan, but then adds on more incentives for healthy behavior, especially smoking cessation and enhanced substance use disorder treatment. And there are the managed care carriers that are operating in the Medicaid plans are also very active in the marketplace plans, and so we can talk more about to what extent is it that the successes of the plan that I've just described, where there's still substantial number of insurers and competition relative to national insurance premiums that are not rising, how does that play with the Medicaid expansion?
Mostly tell us a little bit more about Indiana used the waiver, not the 1332 that Stuart referenced, but the original 1115 waiver to change its Medicaid plan quite considerably and to emphasize health savings accounts, right?
Yes.
How has that worked?
The enrollment has been pretty high, and it has been along the lines of what was projected. So there are about 400,000 people in the Healthy Indiana Plan, all except about 40,000 who, the 40,000 is about how many were in the original Healthy Indiana Plan 1.0, which was the basis for the expansion. So projected enrollments came in line. The reports about the evaluations show high customer satisfaction, a lot of people paying into as you might recall, there is the 2 options of the plan, and those 2 options exist only for those under the poverty level. For those 100 to 138% of the federal poverty level, there's only the the plus plan option. So in one option, you pay into the power account, which is the HSA, and then you get an enhanced set of benefits. You don't pay cost sharing at the point of service except for inappropriate ER use, but then you make these monthly contributions in.
And the state made a substantial contribution to the HSA,
Exactly
right?
right. So this is along the lines of the kind of health savings account that some employers offer, where a large part of that deductible is amount in the HSA is contributed by the employer. So in this case, it's the state making that contribution, and then the individual makes a portion too, up to 2% of family income.
Good. I would certainly entertain questions back and forth in the panel, but let me start a bit by focusing more on the future and where you think competition, what you think would best facilitate competition going forward. And there has been in the previous panel a good deal of discussion about the high-risk people and the problem of the end of reinsurance. What would you do about that if you were designing the next round of reform? Would you do high-risk pools? Would you do reinsurance? Would you keep the corridors? What would you do? Linda?
I certainly wouldn't do high-risk pools. It takes the highest cost, highest risk individuals out of the pool in order to give them adequate access to the medical care that they need. You would need to infuse huge amounts of federal dollars to make that coverage adequate and affordable for them. And that's not the way the conversation has been going. So the levels that have been proposed for these alternatives are basically barely a drop in a bucket for what you would need federally in order to make that work. So I would go number of routes. I would put a permanent reinsurance program in, but I think recognizing the fact that not all of these markets are being adversely selected against. Some of them surely are. It's very obvious in Alaska. There's various different places where it's really obvious, but not all of them are. And we've seen, premiums that are either very close or below adjusted to comparison for employer-based insurance, which is a very broad pool. So, but I would put something in place that would kick in when it was necessary. I would do a lot more investment in
and subsidize it.
Right, it would be paid for through some broad-based tax, whether the same as it was originally through the ACA on all private insurers or through general revenues of some sort. But it would only need to kick in when that selection was actually happening. I would also do much more, as I was alluding to earlier, on outreach and enrollment and increasing financial assistance, because when you bring more enrollees in, you necessarily will tend to improve the risk pool substantially. And so additional outreach and enrollment assistance investments, more subsidies, fixing the family glitch, those kinds of things will bring more people in. And then I think you need to deal with then the concentration issue of the insurers and the providers separately. But I think those are the big issues that will address the areas where there's selection.
It seems to me that you've got a certain number of tools in the toolbox that you can use dealing with these high-cost people. One is insurance regulation, to say we will charge people more towards the same, no matter what their risk is. We know there's all sorts of issues associated with that, with adverse selection. You've got certain subsidy changes. We can change the structure of subsidies to make it more affordable for people who are higher cost and their premiums more available. That's not easy to do. And you're right that if you use, say, a high-risk pool, which was going to be the third thing I was going to say, you can put people into another group in some way, such as Medicaid, which we heard earlier, in terms of which serves that purpose in some states actually, or a high-risk pool or something else. And then you've got to calibrate what are the subsidies, and it's going to cost you more for those people, but it's going to cost you correspondingly less for the others. So I think you've got several moving parts, and we've got to experiment with it. And this just keeps bringing me back to the idea. We don't know the right combination. We don't know what will work in every place and at every time. And that's why I think within this toolkit, we've got to give states maximum opportunities to kind of deploy these different tools and see what actually happens.
So that suggests, with respect to risk, that you would through a waiver process or something, allow states to do with federal money.
Yeah, that's correct.
To try out various versions.
That's exactly right. And
protection.
you know, the 1332 provision does allow a state to use the subsidies differently. And as I said earlier, if you do that, and then you also give much greater opportunity to use Medicaid waivers, such as you have in Indiana, and allow that to be blended together as a strategy, so that the money can be, you know, is porous between Medicaid and whatever you do to deal with these high-risk people. You've got a whole set of possible options to attempt to experiment with. And, you know, I don't know what the right answer is, but I don't think anybody does with certainty. And that's why I think it's important to be as flexible as possible in what a state can try.
I'd say there's probably two ways to answer that question. On one hand, if we are going to have an individual market with guaranteed issue and guaranteed renewability as exists under the ACA, then I think there's reason to believe that the individual market is going to be sicker than the employer market. And part of the reason for that would be that in many cases, people who are in the individual market would be too sick to work. But there's also maybe not that incentive for younger or healthier people to come in. And so because there is the sicker market and because healthcare costs are so high, I think you would need to have a heavily subsidized market for that to work, not just subsidies for the people who are signing up and maybe more broad subsidies that go beyond what's in the ACA to include people who are higher income, but also some sort of cross-subsidization for the insurers that are participating in that market through reinsurance. So maybe a permanent reinsurance program, as you mentioned, would be key to keeping that market functioning. I think the other way to answer that question is if we're not going to have guaranteed renewability, you know, in the context of these repeal and replace kind of conversations, or guaranteed access, where insurers can deny people coverage if they have not had continuous coverage, then for that system to be equitable, and then there would need to be some sort of high-risk pool. But for those high-risk pools to work, they need to be adequately funded, and they need to be, again, heavily subsidized for those markets to work and for those markets to be affordable for high-risk people. And I think the question becomes how to pay for that through the tax system, and if there's not some sort of funding mechanism to finance those high-risk pools.
Alice, I would say on the political side, there's a lot of appetite and interest, at least in Colorado, on these high-risk pools. And I don't know what makes them sort of politically more feasible than other alternatives.
But they sound nice.
They sound nice. And the irony for the Institute, where I am, is that we were involved in the dismantling of the high-risk pool about 3 years ago. And now we're being commissioned to do studies about how this might come back into existence. And I would also share that I think that provider competition is something that we should also look at as bringing change to the marketplace as well. So Kaiser is driving up a specific corridor, a highway corridor in Colorado, and that's really changing. They're driving down provider, both physician and hospital rates in those markets. So I think that the report indicates that this sort of balancing or encouragement of competition is something we should look at more extensively.
Why is that happening? I mean, the history of Kaiser over many years was it did very well in California, not very well other places.
Right.
Why is it doing so well in Colorado now?
Well, I think that it might be that the new lieutenant governor comes from Kaiser Permanente, so there might be some the sausage-making element of this. But they also have a commitment to expanding the population and are doing relatively well, except with their Medicaid population in the market. So they've identified this as sort of a deliberate strategy for them moving forward.
And then other providers have to compete. And
that's right. Yeah. So we see others sort of entering that market, but we have seen the rates that are being offered to providers are significantly lower than they have been before.
Let me pick up on the health savings accounts, because Coasley's report of what's happening in Indiana really goes against the stereotype of health savings accounts are fine for rich people, but they don't work for lower income people. And you're saying this experiment is actually working and it has satisfaction levels that are high.
So let me clarify that unlike it's a health savings account in the sense that there is a contribution towards it, but it's also can be thought of as a premium payment because you pay in an amount and then the rest is paid by the state, and that characterizes the model of a state that has a premium contribution. So it's using that terminology, but it doesn't mean that you are exposed to a very high level of exposure the way you would in an employer health savings account to which your employer doesn't give the whole deductible. So IU, Indiana University, has a high deductible plan, but we're given the entire deductible. So this is common in the state, but it's maybe not what you would think of as health savings accounts more broadly.
So then how does it fit, though, with the image of a health savings account, however financed, forces the consumer to shop around among providers? It doesn't really do that.
Yeah, because the amount of the contribution that is paid in by an individual. So at the lowest level of income, you are putting in $1 a month into the health savings account, right? And then everything above that is going to be paid by the state. So that looks also like just a plan where you just have to make that contribution in it doesn't mean that you've got a lot that you will gain or lose. There is the rollover provision. If you don't use any, if you only use preventive care, then you get to roll over a lot of that contribution. And just recently, there are some statistics on how much that rollover happened. I think it was something like 60% of enrollees had something to roll over. But that, I think, makes it very different from the kind of health savings accounts where, because individuals have to be responsible for the first $5,000 of health care, they have a lot of need to compare prices. Can I jump in on
Yes, do that, and then I want to throw it open to audience questions.
Great. I just wanted to mention on the ways in which savings could occur in the future. It's striking to me that we are not hearing a story of there's one national insurer that has figured it all out. It seems like the entity of the identity of the insurer that seems most successful is really region specific, and that goes to the everything is local. So to the extent that insurers learn from these successful insurers, what is it they're doing? I think there's a lot to be learned.
So, questions right here, and wait for the microphone. And as usual, a short question.
Sure. I'm a little surprised not to hear anything about the small business or large employer markets in the future of this. And likewise, can you all comment on the possibility of ending the employer tax subsidy for, maybe use the wrong word, but can any of you talk about that in this context of the future of the ACA?
Well,
Stuart?
I think the parameter we used, I think, all of us, was what is likely given the circumstance right now. And I think given the bipartisan opposition to the Cadillac tax, for example, on high-cost plans, even though I personally think we ought to be going much more towards eliminating the tax exclusion and essentially using that funding for a direct tax system, I don't think it's in the cards anytime soon. So in that sense, I think it's not, I don't know, it's possible within the discussion of tax reform, but it seems unlikely to me that we would go in that direction. I don't think that's a good thing. I just think that that's the reality that we're dealing with.
That's a missed opportunity, in my opinion, that Republicans have favored the capping of the exclusion in the past.
That's correct.
Democrats failed to pick it up. Yes, certainly.
I just want one more thing on the tax exclusion. We've done a lot of analysis that shows that the distributional effects of the tax exclusion are mostly the same as the Cadillac tax. And I don't mind that as a way to be financing healthcare reform. I think the issue is if you start to unravel the tax exclusion quickly and you then start to unravel the employer-based insurance market, and you have, which is something that seems to be underlying some of the intent of these alternatives, and you still have all of the problems that I was talking about risk segmentation in the non-group market, and you don't have protections, you don't have more pooling, you just have more people potentially in a bad situation when they get sick. And so if you're going to unravel the employer-based insurance market, you better have in place a broad-based system of pooling that allows people to get affordable access to adequate coverage, or you're just victimizing more people as you go along.
Can I just ask you something on that regard, though? I agree with that. And unraveling, of course, suggests a chaos, which is not what any of us want to see. But wouldn't you agree that in general, over time, you'd want to see small employers, people who move from employer to employer frequently, you'd want them really more and more in a broad state market, a broader market, than being tied to the employer-based system?
I don't have any disagreement with that, but it depends on what the non-group market looks like.
I
sure wouldn't risk that now, and I wouldn't risk that under any of these alternative proposals that have been floated. I mean, we were talking about that with regard to eventually under the Affordable Care Act, you could get there, but none of us felt like, even when we were having this conversation, that even under the reforms that pooled risk more broadly under the ACA, that those markets were stable enough at this point to risk that. You really have to have a good, stable, adequate, accessible market for these people to move into in order to make that a good option.
In the back, yes.
Yeah, Carl Polzer. I think to really examine this question, also in the context of state flexibility, you need to really step back and look at the architecture of the Affordable Care Act and ERISA, the Employee Retirement and Income Security Act, that regulates employer-provided coverage, and it creates a very powerful federal preemption that has kept states hands off of employee benefit plans. When that law was started in 1974, all the employers provide most of the coverage and they have the best risk pool. Natural selection. All the lives virtually were fully insured and under state regulation. Employers figured out they could come out of state regulation by self-insuring, and now most large employers and most of the lives are out of state regulation. So a state's going to come and ask for a waiver. Can we get our arms around the whole employment-based population? But that's politically going to be very hard because the employer lobbies have always resisted that. In fact, one of the reasons why they put the preemption in 1974 was I think Hawaii was considering universal coverage at the state level and they wanted to block it. So that's a critical issue. It's come back again.
Yes. Just a minute.
The future of insurance companies will be based on their health, pun intended. And their health is based upon managing their risk profile better. And MACRA, under the value-based contracting, has provided a basis for that. And some of the early indications from some of the insurance companies that are using value-based contracting is that there are positive results, not just on rates, but on healthy outcomes of patients. And I would add to that the ACO, Accountable Care Organization. So how might those be used within the insurance industries to promote this work, irrespective of what goes on with any replacement of the ACA?
Anybody want to respond to that? So we have not focused on payment reform in this panel, though I would suspect everybody is for it and for moving ahead with it faster. But it can't be entirely divorced from this conversation about coverage.
I mean, I would say that I think it's really important to have the right incentives in the market in place in order to promote the innovation that you're seeing with payment reform, right? If the insurers have no interest in managing care effectively because they're going back to selecting the best risk, then you lose the incentive for the ACOs and the other types of management. You really need good economic competition incentives in order for that to continue to develop, I think. Do you agree?
Mm-hmm. We can take one more and then we will run out of time. Yes.
Bob Bullock from the Rockefeller Institute. Stuart, you had talked, and I think you're absolutely on point here, about the importance for the federal government as they're trying to repair, not repeal and replace, to not try to do too much, and yet now we have a president who has come out and said we're going to create a healthcare system that's going to do everything and it's going to do it more cheaply. If you're one of the
That, yes.
if you're one of the Republican architects who's already working behind closed doors to try to come up with something, what kind of political calculus can you engage in to try to roll out something that's reasonable without looking like you're walking away from your party standard bearer?
Did you ask me if I am one of the architects?
No, if you were.
If you were.
Oh, if I were. Well, I've written on this just very recently and say if I were, it would be very much kind of go very slowly. And I think if you think about the general challenge of trying to redesign this, not just technically, but politically, how you can square all the campaign promises on. I mean, I don't know the solution to that. I think it's an impossible puzzle to try to solve. But that said, it seems to me that politically what makes sense is to make, first of all, maximum use of what is in the existing law to begin to start going down. That's why I think 1332 is really important. It's in the law. It allows lots of experimentation. That then allows a lot of things to be tried out at the state level. It would give the federal government a sense of where the states are going if they're given this opportunity and what is needed at the federal level. And so I'm a conservative in the sense of saying, I'm not a radical. I don't think that making big change quickly is the solution either to creating a system or trying to repair or revise it. So I think using existing laws, interpreting the existing law as broadly as possible to allow change. And then, trying to tackle some of the issues with like the Cadillac tax, trying to hold the line on that, although I suspect that's not going to happen in the administration. But trying to do things like that to at least get the basic incentives kind of, the best you can, given the political pressures as well as the technical challenge we have to face. I think that's kind of all you can do at this point to have a chance of being successful. I think big change right now is almost certain to be wrong, and not just technically, but politically. And that's why I think going slowly is really important. So 2018, that's what the president just said. Maybe we'll roll over to the next year. I don't know if he heard me or whatever, but he said he didn't tweet me on it.
Well, that may be a good note to end on, because I do think that the idea that this is a complicated, interrelated set of things and can't be blown up suddenly has come across, as it did not in the campaign. And we can hope for a serious effort to work on these problems. Let me thank you all for coming. And one more hope for this immediate future is you will pick up your trash and carry it out. Otherwise, we will have to do that.
Alice has to do it.
And thank you for coming, and join me in thanking this wonderful panel.